Hello and welcome to a new podcast of Wilson Disease for You. I am your host Zarna. I am not just host today. I am also a Wilson disease patient. I have lived this journey. I have faced many questions. So today I am going to ask many questions to an expert which matters to all Wilson disease patients. So for that, please welcome one of the best doctor for Wilson disease, Dr. Aabha Nagral. Thank you, Dr. Abha, for joining us and giving your valuable time to us.
Thank you.
First of all, I want to know this. Today, you are treating many Wilson disease patients. You have also been part of many studies on it. So let's begin with what is your journey with Wilson disease?
Yeah, so there's no short answer to this. Thank you for, first of all, inviting me. Um, I have been involved with rare diseases ever since I trained in the UK at the Royal Free Hospital, where the first liver unit was set up in the world by Dame Sheila Sherlock. Um, and in that hospital, when I visited in the late 90s, there was a separate clinic for patients of rare diseases. And that is when I first got exposed to rare diseases. And when I came back to India and Mumbai, I kind of was fortunate to attend a support group meeting for patients of Wilson's. And from that day, I realized that this was one rare disease where um, one could, if picked up early, if right treatment was given, completely a patient could have a normal lifestyle. So it was from then that I realized the importance of rare diseases like Wilson's, which are totally treatable if detected and diagnosed on time, and also the importance of support groups. So since then, I have been involved in treating Wilson's patients.
Yes, doctor, you mentioned Wilson disease is a rare disease. So why it is comes under rare disease and why this Wilson disease happened to some person? What is the main reason behind it?
So the reason, so it is a rare disease because different people have different definitions. But if a frequency of a disease from a general population is less than 1 in 2,000, we say it's a rare disease normally. But it differs from different organizations. So Wilson's occurs for 1 in 30,000 people. That's the approximate prevalence which has been spoken of for Wilson's. It is again different in different regions of the world. But that's kind of a approximate figure which most people kind of talk about. So it is a rare disease and it occurs because it's a genetic disease. So it is something which the child inherits from the parents, and usually it is part inheritance from both parents which causes the disease, and this is referred to as autosomal recessive. That means you need an abnormal mutation. Mutation is a change in the gene from normal. So you need an abnormal mutation from the father and an abnormal mutation from the mother to develop this disease.
So this is a gene mutation problem, and this is, as you explain us, this is a rare disease. So I want to know this: at what age patient starting showing some symptoms? Is it in childhood, or at what age we can know that somebody have Wilson disease?
So if you're asking me how does a patient of Wilson's disease present, so yes, so Wilson's basically is a disease of copper accumulation. So normally, all foods that we consume, food, drinks, whatever we consume by mouth, has some amount of copper. There are some foods which have much higher amounts, some have lesser amounts, but all foods have copper. And when you ingest those foods, some of it gets absorbed in the body, and whatever is needed for the body is retained, and rest of it gets excreted from the liver through the bile into the
Hmm.
stool. What happens in Wilson's is that this excretion by the liver into the bile does not happen. So it starts accumulating in the liver. And then it also accumulates in other organs. It's mainly the liver. It can also accumulate in the brain. So when it accumulates in the brain, it causes neurological manifestations of the nervous system. And if it accumulates in the liver, it causes liver manifestations. So, what are the liver manifestations? Patient may have no symptoms, he may just have some abnormal liver function tests which are just picked up incidentally, or somebody may come with a acute hepatitis, which means presence of jaundice, loss of appetite, like any other viral hepatitis. But this hepatitis may go on for a longer time than what one expects. Or there may be recurrent episodes of hepatitis or jaundice. He keeps on having jaundice again and again, and people cannot find a reason. The common causes like viruses are not there. Sometimes they develop cirrhosis. Cirrhosis is like a scarring of the liver. The liver shrinks and the liver function gets compromised. So they may come for the first time with fluid in the tummy. The belly is big because there is fluid accumulated. There is swelling of the feet. Sometimes they may come with a blood vomit or black colored stools or deep jaundice, or sometimes effect of what we call ammonia on the brain. These are all complications of cirrhosis. So they may come with complications of cirrhosis. So it's a wide spectrum as far as liver is concerned. As far as the brain symptoms are concerned, they often come with a child who's in school, who's otherwise doing well academically. Suddenly, his handwriting changes, his handwriting becomes illegible, his academic performance deteriorates, and he starts doing not well in his class, in the exams. His speech gets altered, so the speech becomes not comprehensible. It's not very clear. What we call a slurred speech. He can have drooling of saliva. The saliva may drool down. His hands and feet may show abnormal posturing, what we call dystonia, and there may also be slowness of gait. So all these can be neurological manifestations of Wilson's. Rarely they can have seizures or fits, as we call them.
Okay.
So these are neurological manifestations. So it will all depend on whether the patient primarily has liver manifestations or has brain manifestations. The liver manifestations tend to come earlier on in life, usually before 10 years of age, but the symptoms can come anywhere from 3 years of age to 55 years of age. So, but typically, liver manifestation come before the brain manifestations. The brain manifestations come almost a decade after the liver manifestations. Most patients would have either liver or brain manifestations, but some patients unfortunately can have both. The other way in which we pick up Wilson's disease is that somebody in the family has Wilson disease, like a child has Wilson disease, and he has two siblings, one brother, one sister. So we insist on testing the family, and we figure out that even the brother or the sister has the Wilson's disease, but they have no symptoms. But we pick it up that way because we always insist on family screening. And this is referred to as pre-symptomatic Wilson's disease. They are likely to develop symptoms sometimes later in life, but even in the pre-symptomatic stage, if you pick it up, we advise treatment.
Yes, madam. And what I want to know that what test you advise to confirm that this is a Wilson disease?
So there is no one test. Okay,
Okay.
unless we do a genetic test, what we call ATP7B gene mutations, which we look for. If those are diagnostic, then we can say, okay, this is Wilson disease. But about 20% of patients may not even have a genetic test positive. So there's a score. There used to be what was called the Lipzig score, and then we in India, our Indian liver and pediatric liver groups and the movement disorder society group came up with a score what is called the modified Lipzig score. So it is a Lipzig score which has several parameters like serum ceruloplasmin, 24-hour copper, whether there's a family history of Wilson's, whether any MRI changes. So there are several points in that score which we put together, and we say, okay, if they fit a score of 4 or more, then it is likely to be Wilson. So that's what we use generally. So we use the scores and we use the genetic tests, and then we diagnose Wilson's disease.
And as you said, once one patient come from any family, he or she maybe have Wilson disease. Family screening is must for them.
Family screening is very important because the whole treatment and management of Wilson's revolves around picking it up early. because if you pick it up in a very late stage, sometimes unfortunately nothing may be possible. So if we can pick up family members, a brother or a sister, sometimes even rarely parents who are young with the disease, and we start treatment, they can lead absolutely normal life. So it's very important to do family screening and treat them. If you pick up Wilson's, don't leave it at just screening them.
Also, madam, I want to know that some children, I also experienced this. Calm child became aggressive.
Yeah, so I'm glad you have referred to that, that they become aggressive, irritable, demanding, do not take the medications. Parents are, just tearing their hair. They can't manage these children. Yes, we have seen that. And this is referred to as neuropsychiatric Wilson disease. And we do see that those who have neuro Wilson's, they also often have psychiatric findings. In fact, I can remember patients who first presented with a psychiatric manifestation in school, and they were referred to as psychiatric problems. Nobody thought of Wilson's as a possibility because this child would behave very randomly. He used to chase girls in his class, and he had to actually change two schools because he was rusticated from the schools because he was chasing girls in his class. And this was assumed to be a psychiatric problem. Who was otherwise a very well behaved child started doing this. So psychiatric manifestations can vary widely, and I think one should think of Wilson's when somebody suddenly starts behaving oddly. They could have depression, they could have psychosis, there are various psychiatric manifestations. In fact, this child was even subjected to what we call, shocks, electric convulsive therapy, which was in the past used as a treatment for psychiatric disorders. So, yes, psychiatric manifestations are common and are a little more difficult to manage than the other manifestations.
Okay, and as you told, liver may be involved in this, or brain. Any other organ also affected by Wilson disease?
Yes, there are many other organs can be involved, but I would say 90% of the time it is liver and brain. You can have copper deposition in the eye, which is in fact used for diagnosing Wilson's and also to follow up a patient of Wilson's, because these golden green rings in the eye, what are referred to as KF rings or Kayser-Fleischer rings, can actually disappear if the patient has managed to remove adequate amount of copper. So it can be in the eye, but these rings do not kind of interfere with vision at all. They are used for diagnosis and for monitoring treatment. The kidneys can be involved, the heart can be involved, but these are rare and these do not obviously manifest with problems. Patients with kidney involvement they can be joint involvement as well. Patients with kidney involvement can come with bloody urine sometimes, and that can be a first presentation of Wilson, but these are rare.
Okay, so and now we discussed how a patient's present and we diagnosed this is Wilson disease. Now, what will be the approach for treatment? Is it vary from patient to patient, case to case? How?
Yes. So the treatment will be varied. A liver patient, first, if he has complications of cirrhosis, for example, if he has fluid, if he has blood vomits, he'll need an endoscopy. All patients who have liver involvement should get an endoscopy also done to look for varices or enlarged veins, which can rupture and cause bleeding, what we call varices. So if it's a liver patient, you would like to do that. You like to treat the fluid. So you like to do liver specific treatment. As far as the treatment of Wilson's is concerned, the standard treatment is a low copper diet, and there are 4 5 things which are high on copper. There are many things which have copper, as I said, but 4 5 things which we say should be restricted. One is chocolates, especially the dark chocolates which have much more cocoa, have high amounts of copper. Nuts should be avoided. Uh, Shellfish should be avoided. So these are the 3 things. Also, we say organ meats should be avoided, and soya. These are the 5 things which are highest on copper. Then there are several other things, several other food items, but 5 things. The other thing we tell patients, and it's a common practice in India, to it's supposed to be a good habit to serve in copper utensils. So avoid using copper utensils, avoid cooking in copper utensils. People tend to store water and they consider it auspicious and healthy. And now we have some mineral waters which say copper. So I think one should avoid all this. Also check out your filters, water filters and pipes. Often these are copper pipes. So whatever one can do. Some mineral waters have high copper content. So look out for that as well. So these are the things one should avoid. So one is the diet, which will be common to all types of Wilsons. The other thing is the drugs. The drugs also are common, whether it's a brain Wilson's or a liver Wilson's, the drugs are common. The drugs will be primarily what we call chelators. So these chelators get the copper out through the urine. So they pass the excess copper into the urine. So these chelators are two main chelators, D-Penicillamine and Trientine. Now D-Penicillamine is a very effective chelator. Both are equally effective. It's not that one is more effective than the other, but there are some patients who do not tolerate D-Penicillamine. So in them, we use Trientine as a chelator. So these are the drugs which we monitor by doing urine 24-hour urine copper, and depending on the urine copper, we manage to increase or reduce the drugs. I just want to say that it's important as to how the 24-hour urine copper is measured. Uh, so it should not be done like 10 a.m. today to 10 a.m. tomorrow. That's not the right way. The first morning urine should be discarded. The urine throughout the day, through the night, and the next morning urine should be collected. That's how a 24-hour urine is collected. So in India, we mainly do 24-hour urine copper. The methods which we use to measure serum ceruloplasmin are different from those in the West. So we do not do free copper in India. Many people in the West would advise monitoring free copper, but we only do 24-hour urine copper, and we find it correlating very well with the free copper. So that's one thing way in which we monitor. Now what happens when we give these chelators? In the beginning, the urine copper increases because the body is liking to trying to throw out all the urine with the help of the chelators. But once the after a couple of years, they they have managed to throw out most of the copper from the body. The copper is then maintained. Urine copper is maintained between 200 to 500. Now, normal urine copper is less than 40. We do not aim to get it less than 40. That's an important point. We aim to get it between 200 to 500 when patients are on chelators. So, if it is maintained at that is the dose we use. Often at that time, we can switch if we want to from the chelator to the zinc. Now, zinc acts differently from the chelators. So, zinc acts by reducing the absorption of copper. Chelator is getting the copper out of the body through urine, whereas zinc is not absorbing the copper, only what you have ingested through your diet. But zinc acts slowly. So we do not use zinc as a first drug of choice when the patient has been diagnosed with Wilson's. It can be used in neuro Wilson's, the brain Wilson's, but in liver Wilson's, we do not use zinc as the first choice. We use a chelator first, but when you want to put the patient on a maintenance therapy, you can switch over to zinc. So that is how we use copper and zinc. In zinc, we want a urine copper, when the zinc is being given, we want urine copper to be between 40 to 100. That's how we monitor patients on zinc. Sometimes we use a combination of both. So patients not tolerating high doses of D-Penicillamine, we reduce the dose of D-Penicillamine or Trientine and add a zinc. But the important thing is that these drugs have to be taken on an empty stomach. So don't take any food at least 1 hour before or 2 hours after the drug. Patients tend to take both these drugs together. Even if we are giving both these drugs, they are given at different timings. So don't take first Silamine and then penicillamine and then the zinc. If you are giving both together, then penicillamine in the morning and zinc at night. So they have to be separated out. Both have to be on empty stomach with full 1 glass of water, and that's the way to give these drugs. We also say whenever you're giving penicillamine, take pyridoxine supplements with it because it can cause pyridoxine deficiency. So this is the way in which chelators and zinc have to be used. Now in India, we generally, as I said, use D-Penicillamine as the first drug of choice because Trientine is about 10 times more expensive than penicillamine. So only if the patient is not able to tolerate D-Penicillamine, we switch to Trientine. The important thing we need to monitor even in patients who are on D-Penicillamine is a 24-hour urine protein in the beginning. Because some patients can throw out a lot of protein, and in these patients we'll have to stop the D-Penicillamine and switch to Trientine. So that's an important thing to monitor, at least in the first year after diagnosis. Do monitor 24-hour urine protein, and this is often forgotten. So along with copper, measure the protein also, at least in the first year in patients who are on D-Penicillamine.
So my next question is that only that at what duration follow-up should be done? All tests must be done, and patient should consult his or her doctor. Uh, Importance of follow-up.
Extremely important, and I think this is a very important question because we have very unfortunately lost patients because they were initially doing well, and especially we see that in patients who are in their youth, adolescence, when they have been diagnosed in early childhood. In early childhood, the parents are looking after them, handing over the drugs, ensuring they are taking the medications, but in adolescence they are feeling absolutely normal, and they feel that now we can stop the drugs, and that is when the problem comes. We have seen patients going into sudden acute liver failure and they could not be saved. So it is extremely important that this drug has to be continued for life. Whether it is zinc, trientine, or penicillamine, they have to be continued for life. And it is only because the patient is on these drugs that they are doing well. And the moment these drugs would be stopped, uh, either their brain manifestations may get worse, and worse still would be the liver manifestations, because sometimes these patients just come with an acute liver failure and we cannot do anything about it. So that's an important point, that they continue medications however normal they may feel.
So that means, ma'am, this Wilson disease is not curable.
Yes, in the purest sense, it is not curable. But then we have so many diseases which are not curable. Like, for example, diabetes is not curable, hypertension, not curable. But these patients can lead normal lives as long as they are taking their medications. So it's a very treatable disease. Yes, you cannot say that, okay, I'm cured of Wilson's. Yes, only if you undergo a liver transplant, you may say you are cured, but then you are actually, after liver transplant, you are taking more drugs, actually, more than what you would take without a transplant for Wilson's disease. So it is so when patients undergo liver transplant, yes, they are not going to get Wilson disease again. That is sure. But there are other issues which can come up after transplant. So just because you want to cure the disease, you do not advise a patient a liver transplant unless they actually need one. So that's the thing. So yes, in that sense, it's not completely curable, but fully treatable.
Okay, so a liver transplant is also not ultimate solution.
It is not an ultimate solution. So suppose you have a mild liver disease, or even we have patients who have got ascites, who've come with jaundice, blood vomits. I'm talking as a hepatologist. Uh, with medications, all this goes away, and the liver function tests become normal, what we call the recompensate. So, and they don't need a transplant, and they will just be continuing on that one single drug, which is penicillamine. So we often get, I also do transplant hepatology, and we transplant a fair number of patients. So we often get referrals for these patients saying that, you know, their MELD scores are high, they are cirrhotic with so many complications, they should undergo a transplant. But no, these patients, quite a few of them, can be managed without transplant. And I would say that it's always a good idea to treat them uh, as far as possible, if you can, with medications, because transplant is not going to, okay, you may be cured, so called, of your liver disease, of your Wilson's, but there are medications after transplant which are like immunosuppressive drugs which are given to prevent rejection, which are to be continued lifelong. Now these can predispose you to infections, malignancies. There's so many issues which can come up even after transplant, and it is not that they are free of doctors, free of medications after transplant. So we do get these kind of referrals also, that patient has very mild symptoms and they are told you'll be cured of your Wilson's disease, go ahead and transplant. But no,
No, no.
transplant is not the answer for such patients. Patients who come with acute liver failure, sometimes bad neurovilsons who are not getting completely treated,
Mm.
which is called the brain indication for transplant, can be, which has recently been described, may be considered after a multidisciplinary meeting for transplant. But transplant only to be reserved for the select group of patients.
So, ma'am, as we know, if this Wilson disease not diagnosed on correct time, it will be uh, it will put life in danger. But if well managed with medicine and everything, is will it affect on life expectancy?
No, I think if it is well managed and patient is totally symptom free, liver functions normal, neurologically normal after the drugs, it will all depend also on what stage the patient comes. And some neuro patients, especially, we see if they come in a very late stage, uh, there may not be much you could do in a
Mm.
very late stage where they are bedridden, severe contractures, dystonia, unable to talk, unable to even eat. They have difficulty in eating. No. So, in a very late stage, they may not go back to a normal life and their life expectancy can go down. But if they respond well to treatment, uh, yes, they can have a normal life expectancy. I must add here that when you asked about treatment, we talked about chelators and
Mm.
zinc, but there are, especially in neurovilsons, there are many other drugs which are given for seizures, for what we call abnormal tone
Mm.
of the hands, for tremors. So there are specific neuro drugs which are given. I must say, add that it's equally important to focus on speech therapy, physiotherapy in these patients because that also helps in recovery, especially in the neurovilsons.
Okay, ma'am. And you also mentioned some diet restriction, low copper food and all. Any other lifestyle changes needed to manage this disease or any other restriction patient should follow?
Yeah, lifestyle restrictions, not majorly. Of course, we say that be careful about what you eat. Make sure you have been protected against hepatitis A and B, whether you've been vaccinated or not. Because if you already have a liver problem, you don't want another liver insult. So avoid eating street food. General advice which we would normally give to everybody. So make sure that the food that you eat is hygienic. Don't eat street food. Avoid eating raw foods outside. Take regular flu shots if the flu is common in your area. So those are the common general do's and don'ts, but otherwise no. Then there are do's and don'ts, like if you have a patient with cirrhosis and fluid, we'll cut down his salt, increase his protein. So that is specific to his cirrhotic problem, but as far as Wilson's is concerned, these would be the general. And maintain a healthy lifestyle, regular exercise, we would say even to
Hmm.
the general population, all that will also hold for these patients.
And during our life cycle, Wilson disease is there, and that patient got some another disease. How difficult managing multiple disease together with doctors, and when and how patients should mention each and every doctor they visit that they are Wilson disease patient.
I think it's important to mention sometimes the doctors are not aware about the disease, or they may have heard of the disease but they don't know what it involves because it's a rare disease. So, not many doctors would have been exposed to patients of
Hmm.
Wilson's. So, I think it is important. For those with a liver involvement, we tell them that avoid taking what we call NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs, which are all the common painkillers like
Hmm.
ibuprofen, piroxicam, diclofenac, etoricoxib. These are all common painkillers which people use. So do not use any of these painkillers. We give plain paracetamol, not more than 2 grams in a day. So that's one advice we give because often patients take these drugs for pain, fever, and especially if they're going to dentists or orthopedics, they are the ones who often prescribe these drugs. So it's important to tell them that do not give any of these painkillers. Otherwise, I think more or less they can tolerate. I must here talk about pregnancy and Wilson disease.
Yeah.
So most patients of Wilson's are young people, and women will undergo will plan a family, will have want to will definitely get pregnant. So one thing we avoid is intrauterine devices like copper T. Okay, so that is one contraception measure which we tell them. If they're getting pregnant and they get pregnant, we have to make sure and counsel them before that, that you have to have your Wilson disease under full control. before you are planning pregnancy.
Hmm.
That's very important, because if the Wilson's disease is not under control during pregnancy, we cut down on the penicillamine dose, especially in the last 3 months, because that can interfere with healing. So,
Hmm.
in pregnancy, they may have a cesarean section or whatever other cuts are made. Those may not heal very well if they are on a high dose of D-Penicillamine. So, we like to cut down the D-Penicillamine dose and give more of zinc in pregnancy. But that can be only done if your if your liver disease or neuro disease is under full control. Otherwise, you're cutting down on the medications and you're already not well controlled. It can flare up during pregnancy and that can make matters worse. So make sure that your disease is under good control before you plan a pregnancy.
Doctor, I also want to know that when person is decided to going for marriage, how important it is to disclose this disease to would-be partner.
I think for any disease, it's important to disclose, be having a very frank and honest relationship with your partner. So it's a good idea to disclose because you're going to be on lifelong treatment. You can't keep hiding the medications from your partner. And I think if you disclose and the partner is understanding, he will actually help you
Hmm.
cope with the disease. We see in so many support group meetings, partners actually join the meetings
Hmm.
and try and understand the disease so that they can help the patient to cope better. So, a good idea to disclose. In India, typically the in laws also come into the picture
Hmm.
because people often stay as joint families, with though it's becoming less, but they stay with their in laws. So, it's a good idea to involve them as well. And if the family understands that, it will be good for the patient. I know it's difficult because in India there's still a lot of arranged marriages happening. If there's a marriage which is by consent of both, what we call love marriage, there's no problem. But in arranged marriages, it becomes a little more challenging. But for any disease, not just Wilson's, it's a good idea to disclose.
And we discussed pregnancy, but I also want to know, as this is a genetic disorder, so patients' children in the danger zone of Wilson disease.
So whether they can develop the disease,
Hmm.
yes, there is a potential. So the first thing is that if the mother, father, the patient and the spouse are related, have got married within the family, like married to the mama, a
Hmm.
maternal uncle, as we call in India, that's common in certain communities, or cousins get married, there is a higher chance of the children having the disease. But even if they are unrelated, which is also often the case, there is a chance that the children may have the disease. So, for every child of a patient who's having Wilson's disease, who's born, there's a 0.25% chance. Now, what are the chances for the siblings? So basically, since it's an autosomal recessive, if for every patient there's a every child there's a 25% chance of having the disease, 25% chance of not having any disease, and 50% chance of being a carrier of the disease, which means you need two abnormal mutations to cause the disease. So they have one. So if you have one and not two, you are a carrier of the disease. So there's a 50% chance of being a carrier of the disease. So yes, the children, the siblings of the
Hmm.
patient should be tested. The chance of a child having the disease is much lower. It's just supposed to be 0.25%. But yes, one should even
And
test
is
the
there
child.
any test or anything nowadays available to confirm that new generation is not on risk?
The next generation, you
Yes.
mean? Yeah. So that we have these genetic tests. It's you could either do a ATP7B genetic testing, or what is called a whole exome sequencing if you're not sure it is Wilson's disease. But we have these tests which are fairly reliable. So if you get an abnormal mutation in the what we call the index patient, the patient whom you are dealing with and who's proven Wilson's, then the siblings or even the parents should be tested for that same mutation which is there in the patient. So if you have one child who is known Wilson's, do his genetics. If you pick up what is the mutation in that child, the other members of the family and the parents can be tested for the same mutation. So that makes it also a lot cheaper to test, because in the past these genetic tests were quite expensive. The costs have come down significantly, and if you are testing for very specific mutations, what we call Sanger sequencing, the costs are even lower. So it's a good idea to do that.
Okay. And nowadays we are on, if we try to know more about Wilson disease, uh, we see some gene therapy is going on, some research are going on. So is there any hope for Wilson disease, any new research or anything?
So yes, so you were talking about cure for the
Huh.
disease. So one potential cure is that you replace the abnormal gene itself. So gene therapy has been tried in the US. There are some promising results, but still I think we are a long way to actually have it marketed commercially.
Hmm.
But yes, there are trials going on for certain drugs for gene therapy. All that, there's a fair amount of research going on to develop better drugs for Wilson's disease. Yes.
And also, ma'am, I want to ask a question that some patients have denial. Uh, they're not ready to accept that they have Wilson disease. Some patients do. They start medicine, and they recover, and then they stop taking medicine. What will you advise these people, and how to manage these people? Advice to their family members also.
So I think when the disease, as soon as it is diagnosed, counseling the family and the patient is extremely important. So if it's an 8-year-old child who has first been diagnosed with the disease, I think from that very age, train the child that look, you have to take these medicines. These are very important. What is the benefit of these medications? If they understand that, it is very unlikely that later on in the future they will stop taking the medications.
Hmm.
Encourage, now there is so much access. In the past there was not much access
Hmm.
to Google, and now we have AI. So all this will give you access about the disease, so you can learn a lot about the disease on that. And I think most of the generation today is very smart, so they can use all this these modalities and find out about the disease. And I think we have set up the Children's Liver Foundation. Now this is an NGO which was actually formed by some doctors and parents of patients with rare disorders and other disorders, liver disorders. So and Wilson's forms a large part of these activities of this organization. So here we organize support group meetings,
Hmm.
and I think that's a very, very effective way of convincing patients to uh, why it is important to take the medications of time, why is it important to, and how it is to be taken on an empty stomach, and why is it important to not stop taking medications. So you have patients themselves. It's not doctors who preach patients in these meetings. The patients themselves come forward, they relate their experiences, and when people listen to patients, I think they are much more effective than doctors telling them don't do this, don't do that. And that way patients realize that yes, in fact we recently had a support
Support.
group meeting, as you know, you were also there. uh, there were patients who came and said that look, I am not taking my medicines on empty stomach. I take it after breakfast. And then there were other patients who came that, doctor, sorry, actually for last 1 month I've not taken any medication. So they actually felt guilty, and they
Hmm.
felt that they were not doing the right thing. uh, and there were patients who also came up and said that this is what we were doing, but this is how we changed. So when patients exchange their experiences, I think it's much more effective for the other patients to relate to them, to understand. Families exchange notes on diets, on the low copper diet. So I think it's very useful to have these support group meetings for the patients and also for doctors who treat them, because we also understand more and more the patient's perspective on the disease, and we then learn many things. So there was this patient who told me that when I prescribed him a high protein powder, he had unfortunately both liver and brain Wilson's. And when I prescribed him this high protein powder, his handwriting, which had got better, actually worsened, and I could
Hmm.
not believe it when he said that. And he insisted, no, it's true. And I said, yes, I must listen to the patient. I asked him to get the protein powder I had prescribed. And it happened to be a soy protein powder. So which we
Hmm.
know, soya is high on copper. And so this is one thing I learned from the patient, that if you are prescribing high protein powders, do not use soy
Yes.
protein powder, however high protein it may be. So he was right, and the moment we stopped that powder, his handwriting reversed back to normal. So we also, as doctors, learn a lot from our patients. So I think these meetings are extremely useful.
Yes, patients also get many benefits. Even I noticed that all over India, from all over India, patients
Yeah.
came to attend this meeting and they learn so many things.
Yes.
And thanks to you and all CLF members for that.
Yes.
And to continue with this, I also remember there was a supply crunch during Corona or before that, and CLF also helped for that also. So
It
can
was, yeah, it was actually before that. It happened in the year 2016. So it's a little bit of a story, but I think it's important to say that because the D-Penicillamine, which most patients were on, suddenly went out of the market. And patients don't keep long stocks. So patients had a small stock, and we started telling them that reduce the dose. Instead of 4 capsules a day, take only two so that you can
Hmm.
last, the stock can last longer. And then we realized that what is called the API, the active pharmacological ingredient, the main ingredient of that
Hmm.
drug, was being imported from China.
Hmm.
And the pharma companies were not finding it cost effective to import it because it's a rare disease. So the number of patients are limited. Uh, so as Children's Liver Foundation, and there were many other organizations, national societies also, who lobbied with the government to say that we cannot stop the production just because it's not cost effective for the farmer. And the government insisted that the farmer should continue manufacturing the drug at a reasonable cost in India. So that was one thing, one advocacy we were involved in as Children's Liver Foundation. At that time, we also realized that some patients actually succumbed, and some patients needed a transplant because the medicine was out of stock. We also realized that Trientine, which is the alternative, which patients started using at that time, was not available in India. It was not being manufactured in India, and people were trying to get it in the grey market at very high costs. And it was very erratic, it was not regularly available. So we again went into that and found out that the actual API, or the active ingredient of Trientine, was being manufactured in India, in
Hmm.
Hyderabad, and it was being exported abroad. It was available in the West since the 1970s, but it was not available in India at all. So, so we said that, again, we lobbied with the government and the pharma companies and said that, why is it that Trientine, which is actually being made in India, the active ingredient
Hmm.
made in India, is not available for the Indian patients? So the pharma companies came forward and they started manufacturing Trientine in India. So we even got Trientine in India at a much lower cost than what is available abroad or what they were importing from abroad. So in a way, this shortage actually helped us to get Trientine to India, and it also gave us the importance of advocacy and how foundations like ours can have some kind of collected effort with the government, with the pharma companies, to get some drugs available. So it was in a way an eye opener about all this.
Also want to ask you that as we are living in geopolitical tensions, is there any possibilities of a drug shortage in future also, or just advice patient should maintain how much stock of medicines?
Normally we say about 3 months,
Hmm.
because bahut zyada, if you keep it too long also, you don't know how they are maintained. Of course, now luckily the Trientine which is available, initially it had to be kept in the refrigerator. Now
Hmm.
the Trientine which is available does not need refrigeration at all. So that's another big advantage, because it used to be very difficult for people who are traveling. How do they maintain the low temperatures, cold storage for that drug? So I would say about 3 months is adequate. So, and we hope that no such shortage comes around in the future, because now we have Indian
Indian
companies making
companies.
these drugs. So we hope that it's not happening again.
Madam, one more last question. Any any particular case or any you can share any success story of a patient or anything which can motivate other patients?
Yeah, two success stories. So there was this boy called Harsh, who was referred to us in a very bad situation. He had fluid in his tummy. He was mainly a liver Wilson's. He came to me mainly because he had liver Wilson's. He had fluid in his tummy. He was all skin and bones, lost all muscle mass. He had had blood vomits. There was fluid in his lungs as well. And he was sent to us for a liver transplant. And family was of very limited means. They could hardly even afford the drugs. Incidentally, we gave a fair amount of help to our Wilson's patients. Of course, we go through their finances, and if we find it appropriate to help them, we do help with drugs, with tests, etc. So this child's family needed that kind of help, and the act of transplanting him would have been a bigger challenge. But keeping the finances aside, we thought let's give them a try with medications. And I told the family that please follow up regularly. We are going to monitor you every week and see if you improve. Uh, you don't need
Need
to go for a
transplant.
transplant. And sure enough, with the right follow up, the right medications, he turned around. And over 6 months, he was unrecognizable. He was like a normal boy of his age. And he follows up to this date and is doing extremely well. So, we have been able to salvage a lot of patients from transplant. I'm not saying that no transplant is needed. We've ourselves transplanted quite a few patients of Wilson's, but many of them who actually get referred for transplants do not need transplants. So I want to give a message to this patient's experience that often we can salvage patients and prevent a transplant. So that is one. And there was this other girl who, Sukanya, whose family came to me. There were four kids in that family, and they came to me with this girl in a pretty late stage. In fact, we were going to have one of our support group meetings, and she was preparing a dance recital for that meeting. She used to dance very well, and unfortunately, about a couple of weeks before the actual support group meeting, we heard that she had been hospitalized. She had been referred to us for a transplant. And she was quite sick and she needed a transplant. But she succumbed. So that is the time when I said, when people succumb, people tend to lose contact with the families. So, but we were very keen, and we actually contacted the family, and we said that like it's very sad that this child could not be saved, but you have three other children. Please get them. We would like to test them, and fortunately or unfortunately, all three children were diagnosed to have Wilson's. They were all what we call pre-symptomatic Wilson's. But the good thing was that they got diagnosed before they had any symptoms, and it's almost now 6-7 years of follow-up. They're all doing well with no symptoms at all, leading absolutely normal lives. So just again a message that please test the children, all your children in the family. If one child has been diagnosed, and let the parents also get tested. So this was an important message from this patient.
So, Dr. Abha, what will be your last and important message to patients of Wilson disease and their family?
So I would say that maintain discipline, and in taking your drugs, in following up with the doctors, remaining copper free, and you'll lead a normal life. That's what I can say.
Any patient or any family watching our this conversation podcast want to connect you, how they can connect you?
So yeah, they can reach me. I can give you a QR code which they can scan, which will have all the details of the appointments, where they can reach me either at Jaslok Hospital or in my clinic, Nagral Clinic at Prabha Devi. They could even write an email to me, so that way I could be reached.
Thank you, Dr. Abha, for joining us and discuss all these things and give knowledge to all the patients. Thank you.
Thank you, and I would say that you could reach me on the details which have been given above. Um, any queries, anything, I'm ready to help. Thank you.
Wilson disease may be rare, but awareness is powerful. More we talk about it, more lives we can save. And that's what motto of our channel. Hope you liked today's conversation. Please send your queries in comment box and please like and subscribe our channel. Thank you.